start recording. You can show your screen and we can get started.
Is Los Angeles online or not?
There we go. I can see that well.
All right.
Is Carlo here?
Yes, sir. I'm here.
Hi,
How are
Carlo.
you?
How are you?
Fine, sir.
Good. I'd like to introduce our students here today. We have David Wiles. David?
Hi there.
And we have
Hi.
Hassan Tariq.
Hi. Hi.
All right.
So we're ready to go ahead and get started. We're giving you the field and we've got the recorder started.
Do you understand that Dr. Jonathan Purvis is online or not? Am I online? Am I talking?
Can I help you?
Are we ready with also with Los Angeles?
I think we're all ready.
All right. So what we're going to do today is to start. Is this the first? It's not the first.
This is your presentation.
Yes.
This is.
No. It's 11:11. Is this okay?
Yeah, you don't have a level.
No, no, it's not that.
You know, this is right.
Try this.
This is this.
There are two missing forms.
Okay. And I want you to offer some copy of the presentation. Yes.
This is the one I just changed.
But it's not complete. You want to show? I can show you my presentation.
Who said it?
You say it's not your slide.
Show me that.
Let me go back. So what you have. This is your
There's one missing.
This is it. But I have another. Computers.
Yeah, but there are changes here that are more important.
Okay.
Okay, we can start then. The title, as you saw today, is the role of coronary spasm in patients with coronary anomalies. And the introduction starts with a summary of the issues at discussion. Basically, we are talking about explaining mechanisms. Oh, this is it.
This is mine.
Mechanism of coronary insufficiency in patients with coronary anomalies. Initially, the problem was explained with anatomy, and this is what you see here in the autopsy of a young girl that died of sudden cardiac death during exercise. The left coronary artery coming from the right sinus of Valsalva crossed to the left in a cross-section in histology, out just inside the wall of the aorta, just underneath the adventitia, becoming very constricted and justifying the intuition that coronary anomalies can be caused of ischemia if there is stenosis. And the stenosis should be seen with in vivo with something accurate as it is intravascular ultrasound that allows you to see not only in a fixed mode but especially in vivo during the action of the heart, the changes in cross-sectional narrowing of the coronary artery is affected by anomalous origin. Here you see in systole and in diastole in a patient with the right coronary artery coming from the left, having severe stenosis. This is the size of the probing device for intravascular ultrasound. It's larger than the opening. The distance from here to there is about 1.1, 1.2 millimeters in diameter. So this is the most severe type of stenosis that justifies the symptoms, especially with exercise. We have seen these conditions in the case of the left coronary artery, allowing for many different patterns of abnormalities. Intramural course is the name for that mechanism of being the artery within the wall of the aorta for a limited distance from the ostium and being submitted to the pressure of the dilating ascending aorta. The most frequent left coronary artery coming from the right sinus of Valsalva is the one that goes at the level of the sinotubular junction, and it's obstructed at this level. But it can go also from the same sinus directly down in front of the anterior commissure, make it difficult to resolve by unroofing. Also from the non-coronary sinus, but we have seen two patients, one in the literature, one in our own experience, in which a normal origin of the left coronary artery was coming directly down from a normal sinus position into the wall of the sinus of Valsalva and becoming epicardial only at the end of the lower part of the left sinus of Valsalva. Now we're talking about how patients with this kind of anomaly, and not the one that we described until now, a left acals, where the coronary artery comes from the right sinus of Valsalva, it goes intramurally and is stenotic at this level. In this case, this is called intraseptal course. The left coronary artery that comes from the right is running straight down at the level of the outflow tract of the right ventricle into the infundibulum to become epicardial only at the level of the interventricular sulcus, which is this, where the LAD is, the diagonal, the obtuse margina 1 and 2. This is left side, this is right side, anterior and posterior in a cross-section at the base of the heart. The problem for us has been for several years to understand if there was a mechanism for this kind of anomalies to have angina, because some patients with this that is normally called a benign condition can also be accompanied by anomalies, by symptoms, possible symptoms related to the anomalous course. So let's see a series of 4 cases in which we show the possible role of spasm to document symptoms or to find a cause for symptoms in patients that manifested with angina, typically at rest. The first case is a case of a patient that started becoming symptomatic recently at the age of 46. He had normal physical activities until age 45, and basically started with angina at rest, especially at night. So suggestive of prinzmetal angina. The patient had to go to the emergency room in 2 occasions before I saw the patient in our center. He was living in San Diego, California, and he was sent with the last of these two episodes that required emergency admission. He was sent to the Scripps Clinic to have a full emergency catheterization because of ST elevation, T changes, evolutionary, and mild elevation troponin. In the catheterization found in the Scripps Clinic, they found what was described as left coronary artery from the right sinus of Valsalva with a course between aorta and pulmonary course or intramural with mild hypoplasia, and they studied this problem of possible cause of ischemia by adenosine FFR, the functional reserve of blood flow that was mildly limited. 0.8 is the discriminatory or the borderline value for significant stenosis. Usually goes with a 70% stenosis that reduces the flow, maximum flow capacity. At that point, the patient was referred to Stanford in the pediatric department of Stanford. They have a rich experience of unroofing of anomalous arteries with intramural course, and they agreed that there was in between aorta pulmonary course and scheduled the patient for surgery. At this point, the mother-in-law came to the picture, and she did, evidently she's a fairly young mother-in-law that uses internet, and in Google she found out that we should have an opinion in Houston. So they sent in 24 hours, we had already a CD with the pictures, and we came up with the conclusion that this was an anomalous artery on the left anterior descending from the right, but with an intraseptal course. And we thought that in reviewing the movies that FFR was probably decreased or limited because of the guiding catheter that was used was positioned in an obstructive position at the ostium of the coronary artery that was fairly small. There could have been spasm. So that was an additional reason to use studies for seeing endothelial dysfunction as a cause of spasm. We advised to continue with the workup to include an acetylcholine test to see if spasm could explain the symptoms. They were very suggestive of angina, spastic angina. In the past, we studied similar cases with intraseptal course of the left coronary artery coming from the right. Do you think we're online? We never heard anything. And in the past, both us and the pathology people concluded that this is a benign condition. And Bill Roberts used this type of anomaly that involves an intramural course in the septum, so with systolic compression, that this is a benign anomaly. But still in the literature especially, but also in our experience, there are cases with resting angina, some cases with progressive cardiomyopathy, some cases with reversible cardiomyopathy, some cases with sudden cardiac death. They were not well documented. There are at least one or two cases that are claimed to be related to an intraseptal course. Several patients have been reported with difficulties in surgery, in doing an unroofing or implanting or bypass surgery. Obviously, all of them implying that the diagnosis was not intramural course, but intraseptal. And This chapter obviously is in evolution, and this is what we found to advance the knowledge of possible alternative explanations of this pathology. In this patient, we suspended all vasodilators and beta blockers for 48 hours. During this period, the patient increased the event of unstable angina, and required in 2 occasions to take sublingual nitroglycerin to resolve the symptoms, so consistent with the presence of spasm. At the initial angiography, we didn't find any changes of spasm, so we gave acetylcholine at the dosage of 100 micrograms intracoronary over 2 minutes. Chest pain occurred with severe characters and no AV block by STT changes of mild nature and hypotension. Angiography showed the left circumflex coming from the normal sinus of Valsalva, the left, but the left anterior descending alone coming from the right sinus of Valsalva. We will show the acetylcholine test in a series of pictures. After provoking the symptoms and showing with angiography the changes, we gave nitroglycerin that resolved both hypotension, ST changes, and chest pain. So everything consistent with the fact that this could have been the mechanism of the symptoms. This is an injection in the left sinus of Valsalva where only the circumflex is originating. This is the initial injection in the left coronary artery. The left is, the left anterior descending in this case. The left anterior descending comes next to the right and goes inside the crista supraventricularis in the right ventricle, and then it becomes intramyocardial, has systolic compression of mild degree at this level, to become epicardial only at the level of the origin of the diagonal. This is what happened in this case when acetylcholine was given. As you see, there is diffuse narrowing of severe degree. This is rarely seen in the traditional Prince metal cases that we have seen over several years and studied with ergonovin initially and acetylcholine now. Usually spasm is localized. In this case, it's diffuse. It's all over the system of the left anterior descending with an ectopic origin. With nitroglycerin, everything returns to normal. Blood pressure, EKG changes, chest pain, and the size of the arteries return to normal. So the patient was discharged on nifedipine and nitro patches that eventually was changed to long-acting nitrates and L-arginine, 1 gram, 4 times a day to restore nitrates in the wall of the endothelium. In the follow-up, for 3 months, we followed this patient, and we heard recently that he is now back to pretty normal activities without shortness of breath and without any chest pain event, neither at rest nor at night nor with exercise. This is the first case, most likely endothelial dysfunction related spasm of the LAD with an ectopic origin. This is another case, a 68-year-old Latin American female with unstable angina, comes from Mexico, has a single right sinus of Valsalva large ostium, you will see at this level, that gives origin both to the normal right coronary artery, which is very large, the circumflex, that is this one up there, this is the cranial right anterior oblique, and the left anterior descending, which is this vessel here. is a cranial right anterior oblique projection. At this point, the ejection fraction is 30%. The patient has, for some months, known left ventricular myopathy. In the presence of this anomaly, and she was referred to our center to consider surgery for an anomalous origin. They had doubt if this was or not intramural in the wall of the left main of the aortic root. This is what happened in these patients with the same dosage of 100 micrograms of acetylcholine, severe diffuse spasm of both the LAD, which is this vessel, minor but also of the circumflex, and especially in the circumflex. Nitroglycerin was given quickly and resolved the symptoms, and both the right and the LAD and also the circumflex recover normal size. Again, we used patches of nitroglycerin initially, and then long-acting nitrates and procardia, and the patient improved eventually because the blood pressure was too low on procardia. She was tried on Norvège, but this didn't work that well. We added L-arginine, but because of symptoms, because evidence of edema of the lower extremities, Norvège was substituted in Mexico for Ranexa, and empirically, Ranexa improved a little bit the chest pain initially, but eventually she continues to be symptomatic, both because of atypical angina and mild shortness of breath. The ejection fraction in the last 3 years of follow-up has improved a little bit to 40%, which is promising. At least it denies the presence of progressive nature of cardiomyopathy, but surely is not normal yet. So a case where nitroglycerin, where antispastic evidence of improvement could be consistent with the role of spasm in this patient with cardiomyopathy. Another patient, even more dramatic, it's a patient that is closer to our experience because he's in a cardiologist, a patient that during his residence and fellowship in cardiology in North Carolina started having typical angina, and eventually I saw him at age 26, but he started at age 24 with recurrent admissions in the emergency room because of typical chest pain, tendentially at rest. He had also sometimes chest pain with exercise, but typically the pain would come both at night or during the day, especially with emotions, and would respond to nitroglycerin. In some occasions, especially more recently, he had also troponin elevation, but rarely. The ejection fraction was still normal, and the diagnosis on coronary angiography from the early age of 26 showed left coronary artery coming from the right sinus of Valsalva with the prepulmonic course in front of the right ventricular outflow tract. And at that time, medicines like before, nitrates, calcium antagonists, and arginine were given and had a discrete improvement symptomatically, but he continued with some spells, and as we mentioned here, he was in the emergency room some 100 times over the last 16 years since presentation. This is the initial movie cineangiograms of a single ostium of the right sinus of Valsalva with a big, large right coronary artery, a big, large left main trunk going epicardially in front of the right ventricular outflow tract that would be here. The left anterior descending starts at this point and is fairly small distally, It has a nourishment 50% from the right posterior descending and 50% from the left main. That is fairly small at this level. It has an unusual homocollateral. The collateral around this site, the wall, is the site of the major spasm. So you understand this anatomy. The left from the right sinus of valsalva with a common ostium and a common trunk, and everything combining in a intracoronary nitroglycerin initial image. This is after acetylcholine testing. This was done also with IVUS that caused severe pain, but even without IVUS, severe spasm at this level and severe spasm at this level of the LAD. If you want to see this, this is an intravascular ultrasound at the level of the proximal left main, and this at the level of the pre-pulmonic LAD, distal LAD, where there was a significant stenosis. The diameter was 4.6 at the proximal level and 1.8 at this level, with the acetylcholine 1.4. Basically, there was a total occlusion of the left main with the acetylcholine. So the patient continued with periods of more or less stable angina over the years, always objecting to the idea of being so aggressive as to consider surgery. He hated the idea to have the sternum cracked, as he saw several patients with that experience that didn't like it at all. He was a non-invasive cardiologist. At this point, though, especially because he had 2 kids, and he was anxious to start playing with them and to get involved in some sports, he was totally disabled and decided to come back for reconsideration of the possibility of doing something more aggressive, hopefully with stents, but if not, with surgery. So he came in September this year, and we did see another angiogram that was done recently in Arkansas, where he was coming from, that showed the spastic left main and hypoplastic bridge of the proximal left main. When he came here, we did another sestamibi stress test. They had chest pain, but no ischemia in the stress test. And we decided to consider surgery in view of the severe symptoms of recurrent angina and disabling symptoms. At that point, initially, he decided to reconsider the options after hearing the surgeon to explain what would be possible doing. Basically, the surgeon suggested to do a vein graft to the proximal territory in the largest segment, which was the distal circumflex or proximal LAD, past the insertion of the left main into the left anterior descending. He heard that story. He didn't like a stent, so he went home another time thinking about surgery, but not having the commitment to the project yet. He made it to Dallas, and eventually was admitted to the emergency room with severe angina again, hypotension, ST changes, mild troponin elevation, and he decided to come back and have the bypass. A single bypass at the left anterior descending was done, but on day 2, a day after surgery, the patient had been off nitroglycerin patches, had severe chest pain that they recognized immediately as typical of his angina, and the ST changes were prolongation of the ST. The QT-C was 630 milliseconds, very ominous for the probability of degenerating in ventricular tachycardia, and suggestive of ischemia without being totally typical. The fact is that the patient himself, a good cardiologist, said, why don't we exclude the possibility of occlusion of the vein graft, as he was quite aware of the existence of competitive flow and the possibility that this bypass could obliterate. So this was the finding during an angiogram. They showed that the bypass, the left anterior descending, the vein graft to the proximal left anterior descending was perfectly functional, and the proximal left main had diffuse spasm at rest that with nitroglycerin improved a little bit, but essentially most of the flow was coming from the vein graft, and the distal left anterior descending was much better than before surgery, but obviously still there was a possibility of spasm at the level of the proximal left main. Basically is a good follow-up because we proved that the bypass is open, and the bypass essentially protects from ominous spasm, even though there is still spasm at this level. As you see, there is spasm even of this collateral that with nitroglycerin opens up. These are very unusual collateral, homocollateral in the left main. So it was a follow-up, and in a week he was out of the hospital with nitrates and procardia still for 3 months, we said, and he's now in the middle of an advanced rehabilitation program where he has no more angina. He has recovered a much better physical capacity. He sends us best wishes. He participated in a couple of meetings of our group on the webinar, so he's quite sympathetic to the cause. The final case is a variation in the symphony. Is the fourth case, a 46-year-old white male, an old football player in his college years, then a military man in the Navy, and finally an industrial electrician. They started recently to have angina at rest, chest pain and shortness of breath, especially with heavy exertion in heat. The last time he was admitted to the emergency room with a spell of hypotension and T changes, but no troponin elevation. The workup included a CAT scan angiography that showed anomalous origin of the left coronary artery from the single ostium in the right sinus of Valsalva. They called this vessel intramural course between aorta and pulmonary artery, and he was already sent to a surgical center for unroofing. That is totally wrong. This is not a case of intramural course, but retroaortic course, and this is the result of acetylcholine at 50 micrograms. It caused the almost complete obliteration of the circumflex and left anterior descending. The left anterior descending in this case is essentially part of the right coronary artery posterior descending. All the septals, we don't have here the complete study, but all the septa come from the posterior descending that reaches the epicardial portion, and with the acetylcholine testing, also the left anterior descending territory, the septals with the circumflex go into a severe spasm. Again, AV block, ST elevation, chest pain, everything resolved with nitroglycerin. So we have now this panorama that is obviously just initial. We started with this routine study of patients with angina suspicious of Prince metal angina, especially angina at rest, in patients with anomalous coronary arteries, especially the left from the right. And we can conclude at this point in this preliminary experience. This is totally new. Nobody ever reported anything of this kind. We saw now cases with prepulmonic course of the left from the right that can cause metal angina, like in the patient with the cardiologist with the metal angina in surgery. It could be intraseptal that we have seen in 2 cases today with metal angina and positive acetylcholine test. The intramural aortic course, the typical cause of fixed stenosis because of the intramural passage inside the wall of the aorta, does not cause this spastic angina, even though patients with this type of pathology can have resting pain. And in the future, I plan to do some cases with acetylcholine testing. The retroaortic course was never associated, in my experience, until this last case that we just presented with spastic angina and positive acetylcholine test. The retrocardiac origin of the left from the right never was associated with spastic angina or studied with acetylcholine test. The case that we just saw of a retroaortic circumflex had the wraparound origin of the left anterior descending from the posterior descending, and that case had the positive history of angina, and now we know related to spasm both of the circumflex and the LAD. So this is what we present to your discussion, that this could be a significant anomaly of the function, not only of the anatomy of these patients, where narrowing is not fixed but intermittent and related possibly to spasm that we can reproduce with acetylcholine test of endothelial dysfunction. And I'd love to hear your comments and experience. In particular, in terms of the implications of these initial cases, we should conclude that yes, spasm should be considered, and acetylcholine could be indicated eventually more strongly than at this early stage, but it should be clear that we're dealing with causing spasm with acetylcholine in cases of confirmed spasm of the left main. So you need to be very careful and very alert. You need to be ready to take care of spasm, and you need to give immediate nitroglycerin if you want to do these studies safely. Nitroglycerin should be given after pulling acetylcholine and not following acetylcholine in the catheter, because the catheter contains about 25 micrograms of acetylcholine. So it will increase the effect if you don't flush with saline before, after pulling the content of the guiding catheter. Eventually, nitroglycerin will eliminate and it never cause ventricular fibrillation or serious irreversible problem, but it is a very tricky procedure when the left main is involved in spasm. This is quite exceptional in the typical Prince metal angina, and this testing should be done with great prudence and alertness. Nitroglycerin should be on standby and used immediately. All right, this is for your further consideration. I want to go back to the orange.
Hello, can you hear me now?
Very well. Thank you, John.
Oh, oh good, because I was listening to everything, but I was muted the whole time, so I couldn't ask any question.
I'm sorry, but we can go back.
I'm sorry too. I unmuted you. I found that out and unmuted you, Jonathan.
Yeah.
I ask all the time if you were there, and I was sure that you were there, but it was not totally sure.
Right. So I heard the whole thing. I've been here the whole time. So this is really fascinating cases. But so what percentage of your patients do you try the acetylcholine test on? Is it just these patients who had rest angina and therefore you were suspicious of spasm, or have you given it to all patients who have anomalous coronary arteries?
Excellent question. And it is correct that I didn't use this, but in patients with very suspicious suggestive history of resting angina, spastic angina on clinical basis. So basically the indication of using acetylcholine is the same as any other patient. But in these patients, I knew already the anatomy involved an anomalous origin. And after this early experience, this is all of my experience, 4 cases. It is only limited to the last 6 months of studies. Is probably 50% of the cases of left main with anomalous origin that I've seen in this last 6 months.
So the question, though, is what is causing this spasm? Presumably there's some endothelial dysfunction, because that's why people respond with spasm to acetylcholine instead of vasodilation. So is it something to do with, I mean, it would seem to make sense since this is unusual to have spasm of this degree and to have it associated in 4 cases with anomalous coronaries, that there's something about the anomalous coronary which also implies some predisposition to endothelial dysfunction.
Yeah, you're right.
It would be fascinating to know what percentage of patients with anomalous coronaries have spasm.
We will find out for sure in patients with symptoms. With the patients without symptoms, I don't expect it, but it could be. That is an active mechanism. I talked about this association with embryologists and anatomists. And for the study, the development of the coronary arteries, note that there are associations between coronary arteries development and the development of the nerves of the heart. The nerves of the heart are affected by, or contributed by the neural crest, cells that come from the spinal cord and go to the root of the common truncus at the time of development of the coronary arteries and invade the myocardium, the ventricular part of the heart, following the coronary artery distribution. So it could be that this is the source of the connection, the association between spasm or dysfunction of the probably the nerve control of the media of the vessels. The fact that is most of these coronary arteries are inside the muscle where nerves don't go. That's interesting. The nerves remain epicardial, and sometimes in the retroaortic course, the coronary artery is inside the fibrous body of the heart, but I don't know yet. It's interesting that you ask for that question, because this will be discussed in a meeting of biologists, embryologists, and anatomists in San Diego. In San Diego, there's going to be a meeting at the early part of April, and this will be one of the subjects of discussion.
And Paolo, have you given acetylcholine to people who have myocardial bridges without anomalous coronary arteries?
Yes, very much so. And I'm following in this the initial experience of especially Japanese and South Korean cardiologists that have a rich experience in their media in those countries. As you know, spasm is more frequent than in the States, most likely. And they've done a large series in the range of 1,000 cases in a single institution, whereby they would use a acetylcholine test in every patient with normal coronary arteries, absence of coronary disease when the patient has evidence of ischemia or suggested history of ischemia. And they found that 50% of the people with myocardial bridge had spasm at the level of the myocardial bridge when you give acetylcholine. So it's important additional information. The intermyocardial course at the level of myocardial bridge may have the same issues of lack of adequate innervation as in our cases with strange coronary courses.
But in your cases, some of the artery is intramyocardial and other aspects of it are epicardial, but the epicardial arteries also had spasm. Is that correct?
You're right. And the spasm is beyond the intramyocardial course. It's interesting that you mentioned this again because the case with the pre-pulmonic course had a myocardial bridge at the level of the outflow tract of the right ventricle, just below the pulmonary valve. We documented this both with CAT scanning and surgery. We have pictures at surgery of a very thin myocardial bridge, but there is a myocardial bridge at the level of the outflow tract that we asked the surgeon to cut off. And he said, "Oh, we're going to put a bypass. Don't worry about the myocardial bridge. It's benign." And it was thin, but it was interesting. I don't know if it would change anything, but it is an interesting comment on where the myocardial bridges are and where the spasm occurs. The spasm in these patients is always diffuse. It's not localized like in patients of isolated myocardial bridges.
Has anyone seen spasm in a myocardial bridge? Has anybody seen atherosclerosis in a myocardial bridge? Have you ever seen any of that ever?
I did, and I will mention that this is both by coronary angiography, but especially with intravascular ultrasound. Narrowing a fixed degree, not systolic only, of the myocardial bridge coronary artery are related usually to organized clots. But IVUS shows it very well, and I've seen at least 3 patients with an LAD myocardial infarction that after resolution of the clot in the first stage with thrombolytics 1, with this, thrombectomy in the other, they showed systolic compression like myocardial bridge at the level of the total occlusion. So in those cases, we published those cases, the myocardial bridge was at the level of the clot. So that is the kind of stenosis, fixed stenosis that you can see at myocardial bridge. Atherosclerosis is extremely rare, and I'm not very interested in talking.
This heart here is the right coronary having the main left coming off the right. That's like the Pete Maravich heart, correct?
I don't remember. He was a single coronary artery. I don't remember the course. I don't think it's published as
Yeah, I think
detailed as.
yeah that was published, and I've got a heart just like that on the wall here that we show. And apparently there was scar tissue at the distal LAD out distally. Uh, there was scar tissue where you would think that there'd probably be the least pressure out that far, and that's where the scar tissue was found that they think caused him to fibrillate.
But did they mention the course of the coronary artery that was anomalous?
They show the picture. It looks like this, uh, and
All
it
right.
and it looks
They
very
finished
much
it.
like this in the anatomy.
All right. Interesting.
Talking about congenital coronary anomalies and
Th-
associated with sudden death.
This patient have triple collateral, evidently because of the recurrent spells of spasm. There was a homocollateral in the left main. The collateral to the distal posterior descending was coming up and providing 50% of the LAD flow. And the proximal posterior descending had the bypasses or bypasses septals. They would reach the left anterior descending during spasm. But we had the almost complete occlusion of the left main. The spasm would, the collateral flow would come from the first two posterior descending were very large, very unusual. So evidently, in several occasions, this patient was able to occlude completely and eventually create collateral flow, which is quite amazing. Are we still live?
Yes, Paulo. Paulo, have you seen in atherosclerosis? Have you seen much main left spasm during cardiac catheterization in patients who have main left disease?
Spasm is very rare and very mild, and in general related to the touching, to the pressure of the guiding catheter or the regular catheter or the wire. But spontaneous spasm is very rare, especially where there is no significant obstruction. But if you have 99% stenosis of the left main, usually it's different, the mechanism that produces total occlusion in those cases. You remember when we were using ionic contrast frequently, if you did at that time ionic contrast angiography in 3, 4, 5 projections with a lot of contrast, you would be able to show even shock from progression of the left main disease to total occlusion. But that was thought, at least, to be related to osmotic edema of the critical stenosis from the ionic contrast. Spontaneous spasm of the left main without this kind of anomalies is quite unusual. With atherosclerosis subtotal, yes, you can see it.
Years ago, when I was doing a lot of casts, we saw that, of course, osteo main left was the big problem in the cath lab, and we decided that we would put nitroglycerin in the catheter, and when we did the
Right.
first injection, we would inject nitroglycerin because we had a certain percentage of people that would go into electromechanical dissociation when you engage the
Yeah,
main
yeah,
left
yeah.
and inject there. And so this was before nitroglycerin was available commercially. So we would take the tablets and dissolve them in liquid and sterilize it and put it in the refrigerator. And we started this protocol for severe main left disease and decided for osteo or tubular main left, we would inject that in the contrast during the first injection. And we did that for a while, and we compared that with our numbers prior to doing that, and we found that we weren't having the deaths that people would have with electromechanical dissociation that were involved with engaging the ostium of the main left. And so at that time, we were theorizing that perhaps there was some spasm. And we did look at some of the cross sections of the people that did die before that time, and we found that they did have some considerable muscle still intact in the main left. And but then after a while, I really wondered if it wasn't really the nitroglycerin that was really causing the effects, because the nitroglycerin came out of the refrigerator. We mixed with a contrast, and perhaps it was hypothermia that was responsible for not having sudden death anymore in the cath lab with left main engagement.
Eric, my theory actually is that the change from ionic to non-ionic contrast made a big difference. Now we don't see any more catastrophe after angiography from left main critical disease. I think it's also your experience, or John's experience, that non-ionic contrast is much more forgetful, or it doesn't cause spasm. John, are you still there? He went to the cath lab.
Let's see, I was going to make another comment about something we've been looking at lately, Paulo, is on some echoes we can't see the origin of the coronaries in adults, and on some MRIs, unless you have a navigator for breath uh, timing, you also have trouble seeing the main left. And so we decided what we're going to do about that, and we said, well, we ought to be able to see it with coronary CT, and let's do a CT with one rotation of the gantry just to look at the origin of the arteries and not do anything else. And we got that down to 0.7 millisieverts. And so we're able to look at the coronary origins with a CT scan without much radiation exposure now with one gantry rotation.
That's very good. If you have enough definition, it's great. Yeah.
Yeah, I'll have to show you some of those pictures sometime. It's very interesting.
Very good.
Well, thank you
We're in the
very much.
process.
It's a great conference and a great meeting. My students, as well as Jonathan, we all appreciate what you do for us, and we've saved these
Well,
because they're invaluable. And so I'm looking forward to April. We'll see if we can get a bigger group together in December or January, okay?
very good.
Thank you so much for your presentation. Appreciate it.
Thank you very much.
Thank you.
Bye-bye, Derek.
Bye-bye. Bye, Irby.
All right. Evidently they don't like